Hello, everyone, and welcome to my podcast, Scott Parker Goes Live. For those who don't know me, I've been called a covert human rights campaigner. Others, I expect, describe me more as a social entrepreneur and thought leader who invented the first business-owned disability network and has a long career persuading senior executives that treating people properly, including people with disabilities, is good for business, and then showing them how. Some argue that I have supped with the private sector devil so long, with that famous long spoon, that I have in fact gone over to the dark side. Whatever you call me, after some 30 years hacking away at this, I'm still asking the questions that I think really matter. Why is it so hard to get "and what about disability" into the ethical and responsible AI debate? Why do so many of the diversity managers who describe diversity as a choice choose not to tackle disability discrimination? And since when is treating people fairly and with respect defined as a choice? Well, I guess you could argue not robbing a bank is a choice. Why do we have health conditions and it's other people who have disabilities? And why do we just take it for granted that HR practitioners don't have a clue about the impact of disability discrimination on, well, their human resources? I don't know about you, but I expect a doctor to know the difference between your elbow and your knee. And with all that said, let's dive into this episode.
Well, hello, everybody. And so I am really pleased today that we're going to be talking to Dr. Nancy Doyle. Nancy, I've known you for ages. I think of you as kind of my go-to whenever I've got questions about neurodivergence, neurodiversity, ADHD, your world. And I must admit, I have more questions now than I've ever had before about this whole phenomenon, if that's what we want to call it, that we're watching. And so, but before we sort of get into those questions of mine, please tell my audience more about you, your extraordinary career. I know with a particular focus, I guess, from my perspective, on the work you've been doing with business, trying to help them to get this right. So tell us, who is Dr. Doyle?
So, Dr. Doyle is a neurodivergent psychologist who did not know she was neurodivergent when she became a psychologist, but I was always interested in disability, employment and inclusion. My first job as an 18-year-old was working in a locally based hospital unit for adults with learning disabilities and autism, as it was termed then, most of whom were emerging from institutions and coming back into the community. And that was a very formative few years of my life, because work was a refuge for me. Having struggled all the way through education, I missed 2 years of high school and couldn't quite get to my A levels. Tried several times and eventually just gave up trying and got a job, and really found that I loved to work, which was a surprise to me, having really not loved to go to school. And so work became my passion. And I decided to go and study psychology because I was cross with all the psychologists I'd met. I'd met terrible ones when I was not going to school, and I'd met awful ones in the social care industry. And I thought, these guys have got it all wrong. You're not messed up if you feel messed up in a messed up situation. Like this was the fundamental premise to my thesis when I was 18, and I had inadvertently, I think, happened upon the social model of disability, which is to look very much at context. So I went and studied psychology and very quickly found business, workplace, occupational psychology, industrial organizational psychology. It has many labels, but it's the psychology of work and human motivation and ambition and career potential and talent. It's the science of leadership, the science of human resources practices, the science of organizational culture and organizational change. And I really, really enjoyed learning those things. Occupational psychologists are sometimes called the sociologists of the psychology world, because everything we're studying is in a context, and the shape and size and dynamics of the context is very much also the data that we process. So it's a very sociological approach. and very specifically around work and employment. So after I graduated and became a chartered occupational psychologist, I worked with people who were long-term unemployed for many years. And I worked doing disability assessments for access to work. And I very quickly noticed that my clients were the same people, just at different stages of their career journey. So the people I was working with in access to work, who were in precarious employment, people who were feeling vulnerable about whether they could keep their job, needed disability supports and adjustments, accommodations, and my job was to assess for those and recommend them. They had the same characteristics as the people that were long-term unemployed. They were often dyslexic. They might have a diagnosis of dyspraxia. We had very few ADHD and autism diagnoses then, but when I think about those clients, they were very clearly autists and ADHDers. You know, you could see that there was some neurodivergence. And so I just started specializing more and more into neurodivergence, became trained to diagnose. And after a few years, I set up my business, Genius Within, which is a non-profit organization that supports neurodivergent adults throughout their careers. So we work in prisons, we work with long-term unemployed people, we work in workplaces, we do the assessments that Access to Work do, we provide the coaching that often gets recommended, but we also support the businesses and the employers. You know, how can we make universal design for people with invisible disabilities? So we know how to make step-free access, but how do you universally design for a cognitive deficit that no one can see? You know, how does that work? So that's very much a factor of my research and my company's practice, and my kind of any innovation I'm doing at the moment is very much geared towards universal design and how do we make this the norm rather than the exception?
Well, if you look at the press, it is becoming the norm, if you like, in that it seems like everyone has some variation on ADHD on the spectrum, wherever. I'd like you actually to take a minute and just help us to understand even the terminology. Neurodivergent, neurodiverse. What's the difference there?
Well, neurodiversity is a property of the species. It belongs to the group, as it were, in the same way that biodiversity is a feature of the globe. Neurodiversity is a feature of the human species. So as a species, we have diversity in our neurocognitive profiles. Some of us have strengths in visual spatial reasoning. Some of us have strengths in verbal reasoning. Some of us have excellent memories. That, you know, we are diverse in that way. So to say an individual is neurodiverse doesn't feel grammatically correct in that respect. So that's why people don't necessarily, a lot of people use neurodivergent instead of neurodiverse. And I would say the majority of the community would vote for the neurodivergent label rather than the neurodiverse label. But there are some exceptions to that. Some people identify as neurodiverse. They don't feel comfortable with the phrase divergent. It implies that they are, you know, different from the norm, that that's something exceptional, that they're in some way othered. And I think we have to respect people's individual choices. Also, there are some people who don't like the language of neurodiversity. They prefer the language of the language of neurodiversity is a neutral language. It doesn't insinuate deficit and it doesn't insinuate superpowers. It's a neutral language. And some people prefer the language of disability. They feel disabled by their differences, by their deficits, and they feel that the language of neurodiversity is kind of glossing over the very real difficulties that they've experienced in their life. So what I would say is the language of neurodiversity feels complex and ambiguous because it is complex and ambiguous. It's not because you've missed a really important bulletin or memo. It's because it is confusing and ambiguous. But just like all diversity and inclusion language can be complex and ambiguous and evolving and changing, if we work in this sector, it is our job to learn it and understand why the language changes and what people mean when they subtly alter the language. And it's also our job to give respect to people with lived experience and how they want to identify. So just as a woman can identify as gay, lesbian or queer, someone can identify as having autism, as being autistic, as being neurodivergent or being neurodiverse.
Even if they haven't been diagnosed by a doctor as being autistic, you can simply say I identify as autistic?
Well, I think, you know, we have a lot of self-diagnosis at the moment, and it's a difficult question because in all the studies I've done, I've never found a significant difference between the self-diagnosed and the formally diagnosed. And I've measured things like work engagement, experiences of exclusion, sleep disorders, cognitive deficits, you know, and actually the self-diagnosed people are quite accurate in that they are experiencing the same difficulties as the formally diagnosed people.
I want to come in there though, because I
Mm,
recently went through that live and self-diagnosis where I answered
hmm
the questions online, and questions like, do you experience stress? No. Yeah.
Yeah.
Then I got 44 out of 50 saying I was ADHD, though what the 50 stands for, I have no idea. And then for the privilege of paying so many dollars a month, I could get a free, except for the payment, plan to help me manage my ADHD and control it and harness it, as though this is actually a personality quirk. So one question I had for you is, we all have
Yeah.
different personalities. You look at the ocean thing
Yeah.
in terms of openness to experience and how agreeable you are and how neurotic you are. Many of the
hmm
characteristics they look for in a personality profile, you'll find in some of these self-assessments that people
You
are
will.
to diagnose themselves as ADHD. What is the difference between having ADHD and having a personality that looks a lot like someone with ADHD clinically diagnosed?
So let me follow up with the pros and the cons of self-diagnosis. So the pros, as I say, are actually in terms of experienced everyday issues, need. There aren't very many significant differences between self-diagnosed and formally diagnosed people. The other issue is that diagnosis is privilege. So if we exclude self-diagnosed people, we are likely to be excluding women, people from Black and brown communities or who have been minoritized by race in other ways, people who are from working class communities. Those people are less likely to get a diagnosis formally. And so we need to be very careful about only recognizing formal diagnoses for those two reasons. And then to your point, there is an absolute wealth of nonsense to support the self-diagnosis. And I think what I would say about, firstly, what I would say about that is that it might not be ADHD or autism, but that doesn't mean it isn't a real difficulty. So, you know, we do have a kind of rush towards these particular characteristics and diagnoses at the moment. They are very popular, and it is dangerous to do a diagnosis online in a cross-sectional way. A diagnosis can only happen with a developmental history. You have to take a developmental history, because if you're having trouble with forgetfulness, concentration, and hyperactivity, well, if you've had that your whole life, then that's symptomatic of ADHD. But if you've just had it for the last 5 years, maybe you have a thyroid disorder. And,
Absolutely
you
right.
know, maybe you've got some trauma in your life. So it is really, really risky to be sending people out for diagnoses using online screening tools. But that doesn't mean that their problems with concentration, hyperactivity, and memory aren't real. It just means that they've got the wrong label, and we still have to work with them at the level of need.
But the big concern for me, of course, is that a diagnosis doesn't tell the manager or the person what to do in a work setting that would enable that person to do well at work. It's just a diagnosis. And if it's
Mm-hmm.
a self-diagnosis using faulty tools from profiteers, then they
Yes,
still don't know what solutions would actually be helpful in the job setting.
I
We're
quite agree.
we're actively discouraging companies from requiring their employees to prove they're disabled enough according to a legal definition to trigger an obligation to give them
Mm.
their left-handed mouse, right? Just give
Mm-hmm.
them the
Mm-hmm.
left-handed mouse. So I think we're okay, we're in alignment on that. But the point at issue at the moment seems to be everyone is demanding a diagnosis.
Mm.
And I actually had a very sensible man in a large company say, I don't pay for someone's diagnosis for epilepsy or for kidney dialysis. Why would I pay for a medical test? Is the diagnosis a medical test? in the same way that being diagnosed for epilepsy is a medical test.
No, it's a diagnosis of exclusion. So you have to rule out all other possible causes of those particular issues. It's a clinical diagnosis, but not a medical diagnosis. So,
Pause. I don't think the world hears that. I don't think the world is hearing that this is clinical, not medical. Help me understand the distinction.
Well, we don't have any biomarkers that can definitively rule it in or out. So there isn't a blood test, there isn't a neuroimaging process that we can use that will say this is definitely an ADHD brain and this is definitely not an ADHD brain. The diagnosis happens with a careful triangulation of exhibited symptoms in a number of different contexts, the developmental history taking, which is something you have to train quite hard to be able to do properly, and then additional tests such as standardized questionnaires, standardized psychometric testing, those sorts of things tend to go with some of the processes. So that's why it's not, a purely with something like a kidney disorder, you can do a blood test or a urine sample and yes or no, is the sugar level this high? Is the protein level this high? Well, yes, then that means this. But it doesn't work like that for ADHD or autism or dyslexia or dyspraxia. So, it is a kind of careful triangulation of psychosocial factors as well as looking for neurobiological markers.
And so what we see, though, is it's represented as you have a diagnosis, which then validates in some way your personality. So talk about what's a personality compared to this.
Bear in mind, this is no different to bipolar disorder, borderline personality disorder, schizophrenia, anxiety, depression, obsessive compulsive disorder. It's no different to any of these things that we can't see. In relation to personality,
and those are disabilities. Let's jump in that moment and say, most people would regard, when I say I want to be a disability confident company, they would expect you to also include in that definition people with bipolar mental health conditions.
Yeah.
But those same companies now are saying we want to value people with disabilities and neurodivergent. So it's not a disability in the same way that bipolar is what they're saying.
It's very much a disability by context. So in order, the question that you were asking me, what's the difference between a personality type and a neurodivergent condition, is the extent of the difficulty, actually. So, and it also depends on whether or not you think personality is nature or nurture. So are we born extroverts or introverts, or are we made introverts and extroverts by our environment and our surroundings?
And can we, through sheer will and insight, change our personalities? So I used to get irritated when you interrupt me. I've learned not to get irritated when you're interrupting. But can I learn not to be disadvantaged by my ADHD, or might say my time blindness? Can I learn not to be time blind anymore because I leave half an hour early routinely?
You can put behavioral adaptations around your neurodivergence, but that doesn't necessarily mean that you're changing your neurodivergence. The difference between an extrovert and an ADHDer is the amount of compromise that ADHDer experiences in areas such as memory, concentration. The level of energy might be very similar, but it's a more complex picture. It's not just about personality. It's also about neurocognitive functioning and the everyday engagement of skills and abilities and how you're able to leverage those to achieve simple outcomes in life. So one of the criteria for neurodevelopmental conditions diagnosis is that it has to be having a negative impact in at least one area of your life. So the reason I have an ADHD diagnosis is because I missed 2 years of high school. And, that was incredibly traumatic. I spent time in a psychiatric hospital. I was incredibly vulnerable, anxious, depressed, unable to really engage socially. And that is a significant damage to my education, so that you have to have something like that to have a diagnosis. You know, it can't be that you're swimming along and everything's fine. It has to be that something is compromising you somewhere. It doesn't have to be quite as dramatic as me not going to school for 2 years, but it has to be something that means that I'm not achieving what I could or should be able to achieve in my life.
So how do you explain the numbers we're seeing now? Isn't it more than 40% of young people are saying they're ADHD or in some way neurodivergent?
Where did that statistic come from? Because I
Well,
haven't heard that one.
it's something that's come out about the Gen Z, and they're, I mean, I was actually playing with the idea that they would soon be neurodominant, because if these numbers that they quote
Yeah.
go up, I'm going to be in the minority. But a substantial number of young people.
I think that the fear of that is the moral contagion rather than the ADHD being the moral contagion. When you actually look at the numbers, you know, prevalence studies of neurodevelopmental disorders in populations can make estimates of what percentage of the population are likely to have these things. And the estimates that we have from good, robust population studies over many, many years are around 5% of the population are ADHDers, around 10% dyslexic, around 2 to 3% autistic, around 5% have developmental language disorder, around 5% dyspraxia. And because there's such a significant amount of overlap, the estimation is that around 15 to 20% of the human population has some form of neurodivergence, which makes sense in terms of the numbers. Like, you know, if you think about 2/3 of the population is going to be average. And then you'll have some of the population that are, you know, incredibly gifted in all areas of thinking. And you'll have other areas of the population where all areas of thinking are compromised, and there are developmental delays. It makes sense that the other half of that third are kind of this zigzaggy experience where some things are compromised and other things are not compromised. So I feel like the 15 to 20% is a reasonably robust statistic. But using those statistics and tracking it forward, it would mean that there would be 2 million people in the UK who should have an ADHD diagnosis.
And
But
what benefit does the diagnosis give them? Why should they?
hold on, you're jumping ahead. I hadn't finished. So 2 million people would have an ADHD diagnosis, but the reality is only 250,000 have an ADHD prescription.
Right.
So that's a considerable underrepresentation. So however we may feel about what we're hearing on TikTok or social media, or the moral contagion reporting that you get from certain elements of the media, the reality is nowhere near that level of explosion. It's nowhere near that. And with the other thing we have to remember on social media is that about 3% of the people that are on social media take up 70% of the space. You know,
I believe that. Boy, I
yeah,
believe that.
yeah. So you've got incredibly loud, dominant voices. And so it feels like there's this overwhelming tsunami,
Yeah.
but the reality is that there isn't. And our worrying about it is the moral contagion.
The reality, though, when I'm talking to business leaders, is they've got hundreds of employees joining their ADHD networks, their neurodiverse networks, that the companies are now investing huge amounts of time and effort into responding to what they see as a tsunami of their own people suddenly coming forward. And so if I want to come back to first to say, how do we get your reasonable voice out there? This discussion has to get out as widely as we could possibly get it out.
I
But
know.
how
I
do we
agree.
tackle this? Are you suggesting that the 2 million who should have a diagnosis, say of ADHD, they should all have a medical intervention, a drug of some kind? Is that what you
Not
were?
necessarily, no. ADHD meds don't work for all ADHDers, and they're not necessary for all ADHDers. So I think there's two halves to your question. One is, you know, the perceptions of business leaders that this is a tsunami of need. For them, it is a tsunami of need, because it was a tiny, tiny, tiny trickle for a very long time, because it was an under-recognized, badly understood, phenomenon in which people were far too embarrassed or stigmatized to even talk about it in a workplace. So that has switched on a sixpence. So that thing of it being too stigmatizing to talk about to, you know, ADHD is the new black in terms of fashion. That's happened very quickly. And so it's going to feel to HR professionals and business leaders like their heads are spinning. And I understand that. That's not wrong. And I think what we have to do there is demedicalize the process. I don't disagree that it is no business of an employer's to be doing medical assessments or clinical assessments on their employees. It's not necessary. And as I'm sure you know, Susan, and probably a lot of your listeners will know as well, the Equality Act doesn't require you to make a diagnosis in order to provide disability support.
Right. Yeah.
So, you know, what we could be doing is just going by need and making this part of performance management and performance appraisal and saying, right, so I have somebody who's pretty good at this thing over here, this element of their job that involves talking to people and going out and doing sales, for example, or teaching, for example. But when it comes to their ability to, you know, stick to a process that's really important for safeguarding or compliance, that or documenting or something, you know, they're not very good. So you can just say that. They don't have to have a diagnosis of ADHD or dyslexia to get support. You can say, this is someone who is good at this aspect and not good at this aspect. How can I support them with this aspect that they're struggling with? And we know what kinds of things support those areas. It'll be things like having quiet space to read and to process information that's quite dry. It will be that person developing enough self-awareness to know that they're better off doing those tasks in the morning than the afternoon, or right before lunch, or whenever it is, you know, they work out their circadian rhythms. It might be that that person needs some strategies to support them of the Pomodoro technique, doing it for 20 minutes followed by a 5-minute break. And you as a manager can support that. You can notice them having their 5-minute breaks and not tell them off. And those kinds of things are basic flexibilities. They're very human-centered ways of managing performance that will get the best out of most employees and form really trusting, good relationships. And critically, Susan, they don't cost money.
No, everything you just said doesn't cost a lot of dollars.
No, it doesn't cost money. What costs money is the assessment and the diagnosis. But the basic flexibilities that support people with those diagnoses tend to be free. You know, in the research that I've done, the most popular adjustment for neurodivergent people is the ability to work flexibly and work in a hybrid format. That is by far and away the most popular adjustment. And, you know, yes, it involves some organization and some planning around communication and the way teams engage and thinking about which hours people are going to be where. But it costs a lot less than, you know, diagnosing 10% of your workforce. And you're going to end up with the same result.
Well, unless, of course, what you get is simply a diagnosis. And there's nothing in the diagnosis that tells you that flexible hybrid working is helpful.
You're absolutely right. Yeah, the diagnosis doesn't tell you what to do about adjustments at all. To know about adjustments, you've got to triangulate between the diagnosis, or rather the characteristics of the individual, the demands of their role, and the environment that they're working in. And you don't know anything about their role or their environment from a diagnosis. So, and you don't even really know that much about the person. You know a very specific thing about them, but not the rest of their capacity. So yeah, diagnosis is very, very limited for helping in employment. This is why what I've been doing at Genius Within for the last few years is developing a digital platform. We've had some investment from the Big Issue Social Impact Fund. We've been working with Birkbeck College, University of London, and I've developed a psychometric assessment of workplace performance. It's not about whether you're a dyslexic or an ADHD, or even whether you have long COVID or perimenopause or multiple sclerosis. It's completely disability agnostic. It's just, of these basic functional tasks that we all need in order to deliver 90% of jobs, which of these do you find easy? Which of these do you find hard? How easy do you find them? How hard do you find them? And then you get this sort of profile of where people are at. And then behind the profile, I've got the 430 currently, 430 most frequently used strategic changes you can make to an environment, your behavior, or to reframe your thinking and handle your thought process. And it will direct you to those things. And I think that's what we should be doing. I think we should completely disrupt the cost model of neurodiversity. The cost model at the moment is all of the money gets paid up front on the diagnosis, and then you've got this trickle. And at the point where the individual is actually getting the help they need to do their job well enough to feel confident and secure in their employment, you're spending hardly any money. It's really easy stuff, but it's taken 6 months and several £1,000s to get there. And I think we need to turn it upside down and go, right, in my many decades experience of this now, here are 430 things that I know really work for people. They are easy and cheap and free to implement. They don't cost money. You don't even have to ask permission for most of the things I'm recommending. So you don't even have to do disclosure. But let me do a little assessment with you and work out which of these you need. Let's start there. And I've been working on this with occupational health companies who are now thinking that we can use this as triage. So we start there and then we go, right, how many of you still need help?
And there's no diagnosis.
No diagnosis
described. Well, of course, that sounds, I'm hearing music in my ears, I think. I'm hearing music. But I want to come back to the reason we're having this conversation, which is the market that I'm equating it on a daily basis with the gold rush.
Yeah, it is. Yeah, you're right.
There's a gold rush out there of selling these diagnoses which do not help managers adapt. And so I wanted to ask you, who sets the, can I just open up an office tomorrow and say, I'll test you for ADHD? Is there no regulator? Is there no ethical standards that apply? Who sets the standard for the people when I Google, do I have ADHD? All these people, including one with nurses in it. There's an ADHD nursing company that I can go to. Who sets the standards for them?
Nice. So the National Institute of Clinical Excellence in the UK set the standards for diagnosis, which will be based on either the International Classification of Diseases manual or the Diagnostic Statistical Manual, one of those two, which are run mainly by the psychiatric profession. But NICE set the standards for who can diagnose and what needs to be part of the diagnosis process.
All those organizations that come up have been approved by NICE.
No, what they will be doing is they will be calling it screening, not diagnosis.
Oh, I see.
And as long as they call it screening and not diagnosis, they can do what they want. And as long as they have a disclaimer somewhere that says, for to explore these symptoms, go and ask your GP for referral, or please contact a specialist. As long as they've got that disclaimer in there, they really can do what they want. But people aren't going to read that, are they? People aren't going to process that. They're going to go, well, I did this thing online and it says that I'm 35% dyslexic and 78% autistic, and therefore I'm probably an autist. So now I'm going to, join all the autism forums, change my identity, feel differently about myself, start talking about myself differently, make different requests at work or in education. And it might not be true. There are, all of these things are complex adaptive behavioral profiles. An autistic behavioral profile and cognitive profile and sensory profile is a complex thing. There are other things that can cause the same symptomatology. It doesn't just come from a neurodevelopmental difference. So the risk is that we're misdiagnosing people and people aren't actually going to get the help they need. If I'm doing a diagnostic history testing and I find out that actually when this person was 15 they were in quite a severe car accident, it's stop, it's back up. Does this person need a neurologist? If I found out that they had 2 years absent from school, I would be investigating trauma for that, not just ADHD. I'd be going, what could have happened to this person that would have made that a sensible reaction from a trauma incident rather than a neurodevelopmental difference. And you have to explore all of those things. And without exploring all of those things, it's very difficult to say definitively whether somebody is an ADHD or an autist or a dyslexic.
So what would your advice be to someone watching this? Do you watch a podcast, listening to this podcast, who's thinking maybe I should get a diagnosis? How do I know where to go? There was an article in the press recently about a BBC journalist who went to 4. 3 of them charged him like £1,000 each, and they just happened to make a living diagnosing ADHD. What a coincidence, one asked oneself. And then he had 3 hours with an NHS specialist who said, no, you don't have ADHD. Should they all be waiting for the NHS? How do you determine
No,
where to go?
no, that show was pretty misleading in that actually there are NHS outlets who are doing an absolutely terrible job of this, and there are private assessors who are doing an absolutely brilliant job of this.
So it's even more confusing than I thought.
Yeah, no, unfortunately, it's not about where you go for the service. It is about the quality of the professional you speak to and the service that you speak to. You know, I think that the difference that program showed was actually the length of time that person spent in the assessment. It was a good 3 hours with the NHS assessor, which is about right. 3 hours, anywhere from 2.5 to 4 hours is a good assessment. You take breaks, yes, but that as a whole amount of time is a good idea. Assessments that are less than that are cutting corners. That it's not giving you time to kind of interrogate and probe and go around. Okay, so you had 2 years out of school. So, you know, was there anything that happened in your early childhood, or how was starting school for you? How was the initial transition for secondary? You know, you don't have to say, did you have trauma? Yes or no. That's a terrible assessment. You have to go around it. You know, how was starting secondary school? So what happened? Did it just gently deteriorate, or were there any significant events? And then you watch how people respond. You know, are they responding by going, oh no, everything was fine, and you can quite clearly see that it wasn't. So, you know, that's the skill of the practitioner, and a lot of very skilled practitioners have come outside of the NHS. So you need to look for green flags in an assessor. So number one, the length of time. Number two, the qualifications that they have. They should be a registered professional, either registered with the Health and Care Professionals Council, the General Medical Council, or the Royal College of Nursing. They need to be a registered health professional to make a diagnosis. Talk to them about second opinions. You know, do they have people that they use for supervision if they're not sure about somebody, or if they think that they need to refer them on? So, for example, if I was diagnosing and I thought that this could be a head trauma, or it could be you know, an emotional trauma, I have to have someone I can refer that to, because that's now outside of my scope of what I'm trained to do. So talk to them about how they handle things, like if something is outside of their scope. And then the absolute marker for me is ask to see an example report. Ask to see what, you know, can I have an example of what I will get as a report if I pay for a diagnosis with you? And then have a look and see what's in there. You know, does it read well? Does it have a range of kind of assessments? Is it a good balance between developmental history, standardized questions and questionnaires, current performance and current issues? You know, what are they using? Is it a broad range of assessments, or is it just one thing? One thing is not good. Broad range is very good. Can you read it? Does it make sense to you? Do you feel good about the information if you were getting it? You know, does it help balance your,
Right.
you know, those are the things you should do. So yeah, I don't think it's as simple as NHS versus private.
That's good to hear. We wouldn't want anything to be straightforward and simple in this game.
Right.
Come
Yeah.
back, come back. But I think what you were saying earlier is actually you don't need a diagnosis. Everybody doesn't need a diagnosis.
No, I think, you know, a diagnosis can be really vindicating and cathartic. So a diagnosis for me meant that I stopped giving myself such a hard time about the ways in which I'd failed, in inverted commas, as a teenager. So I stopped kind of being guilty for that and feeling like I'd caused everybody so much trouble and it was all my fault. I was a bad person and I needed to spend the rest of my life making good on what an actual pain in the neck I'd been for 5 or 6 years. So I forgave myself. And it also meant I stopped trying to be the person I'm not. So right, do you know what? I'm going to struggle to remember people's birthdays. That's just something that happens. And rather than trying to remember their birthdays and then chastising myself when I forget, I'm going to stop trying. I'm going to set up a system for this. And on the 25th of every month, I get a little automatic email that tells me all the birthdays that are in the following month. And I've set this up and it happens every year. And that just goes round and round and round. So, you know, that's the sort of thing that can happen for a diagnosis. And for an individual.
But you can do that without a diagnosis.
You can do that without a diagnosis. You can do that from doing an assessment like the one I've created, like the Genius Finder. You can do that with just developing self-awareness, having some coaching, reading some self-development books, and getting onto that kind of self-awareness, personal development train. But I do still think a diagnosis is useful for individuals. But for the workplace, it's completely unnecessary. For the workplace,
Completely
it's about,
unnecessary.
yeah,
Let's say that out loud.
yeah,
Completely
yeah.
unnecessary. That is such an important insight.
And the other thing I think we have to ask ourselves is not why have we got so many people coming forward for diagnosis, but why are the people who used to fly under the radar now so compromised that they need a diagnosis in order to be able to thrive? That's the other question.
Are they compromised or are they empowered by the fact that it's fashionable and they can come out and declare it?
I think they're compromised. I think the reality is they're compromised. The idea that they're somehow enabled is part of the moral contagion that I think
That's
is
very strong terminology, moral contagion. Explain that.
Moral contagion is when you have a kind of a fear factor, like we've decided there's something we're going to be frightened of. We engage in confirmation bias. So we see our algorithms on social media start feeding us the same content over and over again. We become really, really angry and upset and fearful of a social phenomena that actually affects a rather small amount of people and is nothing to do with our everyday lives.
Right.
That the satanic panic in the US in the 1980s is a great example of this,
Sure.
So I think the moral contagion is this idea that there are lots of autistic people and ADHD people, they're taking over the world, they're demanding things, they're having economic privileges. The reality is they're not having economic privileges, they're not taking over the
I
world.
certainly haven't heard any of that, I must
No.
say. But
Well, if you read a certain Conservative Party leader nominee and candidates' recent writings, you will find that in them. Yeah.
what I am saying are things like there's no deficit. All ADHDers are creative, wonderful people. It's that superpower thing. We're all fabulous, and it's not a disability. And then, maybe it is a disability. We've got a legal right to force employer. Oh, maybe we don't have it because we're not disabled, really. Hence, disabled and, I never see disabled and quadriplegic.
No.
Like, no.
No, yeah, I mean, there's a certain amount of internalized ableism about that, isn't it? I don't want to say I'm disabled, so I don't want to associate with disability because disability is less fashionable and more stigmatized still. And I think that's a concern actually for the whole field. It bothers me greatly. But it does, the thing about neurodivergence is you can be simultaneously enabled and disabled in life, So when I'm doing talks or podcasts like this, I don't feel disabled. I'm not disabled. I'm actually perfectly enabled in these contexts.
But a paraplegic would say the same thing, doing this
Well,
interview. I'm
exactly.
not disabled.
Exactly.
It's just, I can't get in your damn building, he would argue.
Exactly.
That's my disability.
It's the social model of disability, Susan. Exactly that. It's exactly the same. It's the social model of disability. And the other thing that I think what has changed in the last couple of decades is that the social parameters that compromise neurodivergent people have increased. So more neurodivergent people are compromised than were when I was growing up. So when I was growing up, I walked to school. There was no social media to distract me. I had plenty of times where I was quiet, where I had no input, where I would just listen to music or just be sat waiting for a bus looking at the sky. So nobody needed to teach me mindfulness. And as a result, the level of hyperactivity in my thoughts was much calmer. I went to a school where I didn't go for 2 years, but they gave me permission for that. So what I actually used to do is go in on a Monday and pick up all my work and go home and do it. Now, there is not one school in the country that would give me permission to do that today. Absolutely not one school in the country. And what would happen as a result is I would have ended up in a pupil referral unit. My parents would have been prosecuted. All hell would have broken loose. So I would have less freedoms as an ADHD child today than I did growing up in the 80s and 90s. And as a result, I would have needed that diagnosis harder and faster than I do now. So I would have fought for it harder and faster than I did now. Does that make sense?
Yes, it
And
does.
I think it's the same in workplaces, the ubiquitousness of things like Slack channels and team chats and the overwhelming tsunami of email that kind of, we are definitely drowning in that tsunami. That's not a moral contagion, that's a fact.
That's a
So
fact.
yeah, so there's lots of ways in which work and education and society has changed that make it's harder for neurodivergent people to cope. So more of us need a diagnosis.
How interesting. I feel like I'm supposed to say things now like, well, as we're drawing to a close, I've lost track of the time entirely. We started and we've come back to the tsunami metaphor. What would you predict, your final sort of thoughts, 5 years from now, if we had this conversation again? What do you predict? What would everything have simmered down? Would everybody saying, yes, it's a disability, and yes, we just need to be flexible and use your tool? Where's it all going? Will the cowboys, like that Liven outfit, will they have died, or are they making so much money they're going to be there for a long time?
I think there's a utopian and a dystopian possibility. I think that's generally true for the world right now in lots of spheres, not just neurodiversity. But the utopian answer for me would be that businesses have taken the lessons of neurodiversity and used those lessons to make workplaces more human-centered. And more personalized and customizable. So that's the trajectory of the 21st century. The 20th century was characterized by homogeneity. We needed automatons. Everything had to be done in the same way. It was still very much the industrial era. We needed humans to be automatons that delivered the same type of work in the same way. And so there was lots of standardization and bureaucracy. In the 21st century, our media is personalized, our medicine is becoming personalized, but our work and our education is still standardized. And that personalization, you can work out how to do that by listening to neurodivergent people. There's a brilliant book by one of my brilliant peers, Dr. Ludmila Praslova, who is a professor at the University of California. And she has written a book called The Canary Code. And she's using the metaphor of canaries in the mineshaft. So what she's saying, and I absolutely agree with her, is that neurodivergent people are the canaries in the mineshaft. We're highly sensitive to certain things. So we start cheeping way before everybody else does. But if you make us happy, if you reduce the impact of the things that are bothering us, it will actually have a positive impact for everybody. So that's the utopian future, is that we listen to what neurodivergent people are asking for. We build flexibility and output focused performance management into our HR systems and businesses, and we create the conditions for good performance. And therefore, we don't need so many diagnoses, and we start to simmer down and stop talking about it so much. And the people who end up getting much more intense help are the people who can't work at all, or who are in prison, or who have, are in much, much more dire states. The dystopian future is that we continue to diverge, and we have at the moment, I think, a very different narrative in communities of lived experience to communities of work and human resources and employment legislation. And those two narratives are getting further and further apart in terms of what's possible. And in the middle of those two communities, you've got the snake oil salesman. You've got the people who say, I can solve this big problem for you with my, with my online screening diagnosis thing that will tell you, that's the nonsense. And there's going to be more of that, I think. I think there will be more of that.
Thank you very much. I'm going to just arbitrarily say thank you, because I could start another train of thought, but I mustn't.
Thank you.
As ever, Nancy, really, really helpful. And I'm sure that my questions would be echoed around many, many, many of the players that I hope will have an opportunity to hear you and see you. So thank you.
If you found this content relevant and perhaps even thought-provoking, please feel free to share with your networks.